Hi, everybody. We want to welcome you to our final episode for 2025, and it'll be an office hours program where we're going to just look back at 2025 and see some of the interesting things that have happened, predominantly about the chiropractic profession, but we'll bring in some other things about healthcare in general. And offer some commentary and some ideas for what to consider looking forward to in 2026. So, welcome our panel, Marcia and Don and Brian, David, and we're joined by Dino Del Mastro, who presented one of our other webinars. So, hopefully, we'll give you some interesting information to think about as 2025 closes and areas you can focus on for 2026. So I guess what I'll do is I'll just pick one of these topics that have come up and then ask for some commentary from Marcia and, well, from everybody. Dino, feel free to join in too on this topic. So I think what we'll do is we'll start with, let's start with this. See if I can share my screen. Okay. Oops. I guess I have to stay in here. Share my screen. Allow. Okay. I think if I share this, it'll allow me to. All right. Can you guys see this acute low back pain guideline on the way?
No, we got your email. You need to share a separate link.
Okay. So wait, let's go back. Let me stop sharing. And let's see if I can do it this way. New guidelines. I see. You have to bring it up first and then it allows you. So you can see this acute low back pain guideline on the way?
Yep.
Okay, good. Then the first thing I'm going to do is ask for any of you on the panel to tell me what you think when you hear there is a new low back pain guideline published.
Same old usually.
Yeah, anything else? Yeah, I think exactly what Marcia did. Same old, same old. Why are you? I mean, we have so many guidelines on back pain that are never implemented that it seems ridiculous to be publishing a new one. However, there is a bit of a caveat to this one. So when we and this was led by Jessica Oswald, MD. She's an anesthesiologist specializing in pain management. And I do like this. Let's see if I can drag this down now. Oops, there we go. 3 areas of recommendation. So they're focusing on the management of low back pain in 3 areas: self-management, clinical management, and opioid management, which is I think if there's anything that's pretty commendable that they decided to focus on those 3 areas, because past guidelines almost exclusively focused on clinical management, right? I mean, there's at least 10 international published guidelines on back pain, most of which has never been implemented, certainly not on a broad scale. There are isolated pockets of it, which is pretty much the work we were trying to do with Spine Care Partners and had some measure of success with. But to focus on self-management, I think, is really good. That's what we're trying to do with our app, The Back Road, and other companies who have developed similar apps are trying to do is how much can we self-manage? One of the, a little call out to our Back Road app is it's also a self-triage as well as self-management. Then everybody is focused on clinical management. The big bugaboo there is how are you going to actually implement that information? And then opioid management. And there were, this I'll bring up and then you guys can talk about. There were 2 published papers in 2025. Anthony Lisi, who we all know, published one of them in the Journal of General Internal Medicine The second one was by Traeger, Trager, in PLOS One. You, Marcia or Don?
Yep.
You know him?
Oh yeah. Yep.
Sure.
Mhm.
Okay.
I know
Good
him
work.
from a distance. And he's done
Yeah.
incredible work. Yep.
Oh gosh,
Yep.
wonderful.
Yep. Definitely heard of him. Yep.
Okay. All right. Really good. And both of them showed that when you use chiropractic care for back pain, and Anthony's was focused on the VA, you see decrease prescribing of opioids. So when chiropractic care was involved in the case, so that pretty much tells you how you can manage opioids better, other than just don't prescribe them, get a chiropractor involved in the case. Then there tends to be fewer opioids prescribed, which is interesting. Any comments you want to throw out relative to that?
Yeah, the both those studies were really good, well done, and I know the Triggers was a systematic review. I think no, it wasn't a systematic review, but it was a claims data through Medicare, and so it was huge sample size, and so very robust data. So this is not run of the mill type study. This is a really, really well done, and again a large sample size. So I'm hoping this is as influential as it should be in our view. So it's but it's hugely important for the system.
Yeah, and I would just comment that that's very consistent with a lot of literature that's been published in the physical therapy realm, on just physical therapy management in general, but also inclusive of manual therapies and manipulation. That opioid utilization prescriptions are associated with a lowering of prescriptions with that type of care. So it's very consistent with what's been out there for at least 5 or 6 years. So, yeah.
Hey, do you think I mean, the reason behind it is it's change? I mean, is it just that it's keeping the patients away from someone who can prescribe, or do you think it's actually changing the behavior of those who are prescribing?
I kind of just comment that it's especially associated with early intervention by a conservative practitioner.
Yeah. Okay.
So it probably is averting the prescriptions,
Yeah.
but also getting the patients actively involved in their care early on, which
Yeah.
avoids this ongoing pain, which results in people getting more desperate for solutions.
Yeah.
Yeah, that's a very good point, Marsha. Because looking at how human beings work and how they function, nobody has back pain and they decide I need an opioid.
Yeah.
They just need help, and so it's us that influences them to get an opioid or not. Us meaning the healthcare system.
Yeah.
How we handle it is what is the biggest determiner of whether they ever have an opioid or not. And
Yeah.
if we never mention opioid and we start getting them on stuff that leads to benefit, then opioid never comes up.
Yeah. I would further comment, because I totally agree, Don, that in New York, when we were looking to adjust the fee schedule for workers' compensation, we looked at data on what were considered to be benchmark states where their systems were considered to be very robust, and they had low indemnity cost, and their overall cost management was superior. But what we were able to show the workers' comp board was that the PT workforce seemed to impact and be associated with the rate of prescription for opioids. New York was 5 times what Washington State was at the time for opioid prescriptions. And that was critical in actually them changing the fee schedule for New York for workers' comp. And now they're actually encouraging participation in the workforce now, in the workers' compensation workforce.
Can you clarify what they're encouraging?
They're encouraging, yeah, they want to increase the workforce. They're actually reaching out to the professional association. What can we do to get more physical therapists in the system?
Oh,
Yeah.
okay, great.
Yeah.
Oh, that's really encouraging. Yeah, wonderful to hear. Yeah, you brought up a really interesting point, and that is early care. And what happens in the beginning seems to set the tone, which is why, getting primary care physicians who see the majority generally of back pain, neck pain patients as the first point of contact within the healthcare system. Chiropractors are way up there. Hopefully, they can make physical therapy higher up there too. But at the very least, get the primary care docs to stop prescribing opioids, and then get the primary care docs to get patients over to chiropractors and physical therapists as early in the course of the condition as possible. So,
to speaking of that, John, can you scroll down a little bit? Because
yeah,
on physician management, it talks about referral to physical therapy. I'm thinking that probably doesn't say referral to chiropractors. No. Well, manipulation and mobilization, if you for what it's
yeah.
worth. That's kind of interesting that we're not even mentioned.
Well, it does say manipulation, and
Yeah.
that's pretty heavily associated with chiropractors.
Yeah, that helps.
Yeah.
but
Yeah.
we still, in so many of these discussions, we don't even exist
I know.
as a
I know.
profession.
I'm sure, and they didn't even mention. Well, they did say psychologically informed physical therapy.
Yeah.
But they don't even have the courtesy to mention chiropractic alongside manipulation.
And the other telling thing here is that they talk about techniques or approaches, like they say non-steroidals, muscle relaxants, and then physical therapy and manipulation and mobilization are talked about as if they're just another modality of treatment. That's the other thing that we see so commonly in these guidelines that are not produced by physical therapists and chiropractors.
Yeah.
They treat us as if we're a therapy rather than a professional group.
Yeah. Well, they do the thing. They certainly do that to physical therapy.
Yeah, don't get me going on that. It's as though physical therapy is just this package of interventions that are consistent across physical therapists.
Yeah.
And the other thing that jumps out at me here is that it referral to physical therapy, manipulation, mobilization. Let's say that's chiropractic, acupuncture. Well, if they're gonna get all those things, then we should get the message out to the patients. Save the step. Don't even go to the physician. Go right to the physical therapist or chiropractor.
Yeah.
It saves the extra step because they're going to send you anyway.
Yeah.
And everything that you need other than the non-steroidals and muscle relaxants, which, those two things, if they get a non-steroidal or a muscle relaxants or not, is that going to make or break the case? Hardly likely.
And they can get the NSAIDs over the counter.
Exactly. Yeah, that may help a little bit, but so that's the other thing that jumps out at me here.
Yeah.
And I would just further comment that something I wanted to comment on earlier. These are the problems with clinical practice guidelines because they're just too general, and it's how do they get implemented? How does a payer evaluate whether you're following those guidelines? Is it based on claims data? And so there is an attempt, I can say, in the orthopedic section of the Physical Therapy Association that they're trying to alter the guidelines to put a little more meat in there in terms of, from the payer perspective, how could I use this guideline to evaluate, the value-based piece of the care?
Yeah, that brings up a great point, which is the system doesn't reward those who follow the guideline.
Yeah.
Right. Right.
So there is no value-based reimbursement per se I don't think with back pain. Yeah. I mean, there are for a couple of conditions, I think, where there actually is some type of a reward based on your management of a particular condition or possibly a punishment if you don't. But
yeah, the systemic incentive is to not follow guidelines. If you really want to make a decent living in healthcare, do not follow guidelines. That's the last thing you're going to want to do.
Yeah, and it's sometimes, they feel it's more expedient to just give them the prescription and let them go.
Well, the frustration that I've always had with guidelines in general is that good practitioners don't follow them. Good practitioners don't need them. Bad practitioners don't follow them.
That's interesting. And just a further angle here, because I've been looking into this a lot lately, is that, in New York anyway, in other states, for the workers' comp system, they have medical treatment guidelines. Those are very granular. Okay. They give duration and frequency recommendations. Now that's something, and what happens is that if you have a condition that falls under the medical treatment guidelines, you don't require any prior authorization for treatment. So, but again, because clinical guidelines really aren't followed, the payers largely are implementing prior authorization processes that delay care and limit care. So
they can't seem to let go of this desire to prescribe a short course of short-acting opioids may be considered in select patients when benefits are likely to outweigh harm. But, do you remember I wish I could, Don, you may remember who published it, the study that was a comparative effectiveness trial for hip osteoarthritis, low back pain, and knee osteoarthritis, where they gave them an NSAID, a acetaminophen, or an opioid. And the effectiveness was as high, if not higher, for the NSAID and the acetaminophen than it was for the opioid. Yet they're still trying to justify pushing an opioid for these musculoskeletal complaints.
And it says in select patients when benefits are likely to outweigh the harms. I'm hard pressed to even figure out what situations could possibly be one in which an opioid has more benefits than potential harms. I can't even think of a clinical scenario.
Certainly not in the realm of musculoskeletal care. I mean, if you're a cancer patient, then okay, bets are off in this regard. But for musculoskeletal conditions, you don't typically die from these things, and you manage them. And so, what's the point of the opioid if it doesn't do any better than an over-the-counter medication? Why are you using it at all?
I think some of this is political, John, because there was a lot of pushback, after that, in the late, say, around 2017, 16, that's when this realization came that we have an opioid problem in the country. But there was a lot of pushback from medical providers. Well, we just don't want to throw the baby out with the bathwater. So, there are people that benefit from opioids. And so there has been a kind of a political pushback on not going too hard on the elimination of opioids from treatment.
Yeah. Well, show me the evidence.
I couldn't agree more that I can't imagine, a situation with musculoskeletal care, except potentially for post-surgical conditions. But that's another issue, because there are systems that don't use any opioids. They have protocols that avoid opioids, and their outcomes are just as good.
Yeah. If we're going to really be evidence-based, then let's apply the evidence. What does it tell us? And right now, it's telling us it's, at least for these common musculoskeletal conditions, it's no better than over the counter. So I don't see where they can even justify that one statement in there. But again, I don't see that they've addressed implementation. So it's another exercise. To me, it's another exercise in academia. I like the fact that they mentioned opioids. I like the fact that they mentioned self-care as two of the three priorities. Clinical management, well, you've got 10 other guidelines to draw from.
Yeah. Sorry, I didn't mean to cut you off, John.
No.
Can you scroll down again?
Yeah.
Because even in the self-management, it's all generic stuff. Tell them to be active. Okay, that's good. But what are there certain activities that they should kind of curtail for the time being? You know, all those things are, you know, the devil is in the details, and superficial heat and non-steroidals. All right, fine. But, you know, that's half of the bulleted items, basically, are passive things. You know, there's a lot more to self-management than these 4 bullet items, but that they wouldn't know, I think, you know, if we with our experience with, you know, this particular professional group, they don't generally have a good knowledge base and experience on specifically recommending certain activities and self-care strategies versus other ones.
Yeah, and absolutely, Don. I think you're spot on. I'll give a little shout out here to Christine Gertz, who's doing, I think it's on LinkedIn.
Yeah.
She's doing a series on Santa Claus for the holidays. Santa Claus has back pain.
Right.
And she's starting with superficial heat, one of the recommendations from this guideline. So I wrote in and said, I don't know, seeing the physique of Santa, I think you're better off starting with some weight loss and core strengthening.
Yeah.
Next, I'm going to send you need, it's not back pain, but you need to focus on he's probably got metabolic syndrome.
Yeah, right.
It's all visceral fat, and he's probably hypertensive, and
Yeah.
and his body's in a state of inflammation.
Yeah.
You need to get him on a Mediterranean diet.
Yeah. Yeah. If you think about all the sweets on the North Pole, I mean.
So, you know, Christine's starting. It sounds like you know, from these guidelines.
Yeah.
All right, great. Let's jump to another topic here. So I'm going to stop sharing. And if there's anything you guys want to jump into,
John, perhaps I'll jump in quickly, because the one that popped up on the social media feeds in 2025 is the wearable devices and the nocebo effect on patients. And I'm kind of bringing it up because it actually, I would say, affected me somewhat this year, because I got a Whoop device.
tell me about it. I'm not even familiar.
Yeah, so the Whoop device is one of the wearables. It's considered to be sort of one of the higher end ones for bio tracking.
Okay.
And it's got really high end cardiovascular tracking as well. So I've got that because of my history with cardiovascular issues. And it's interesting that it gives you this recovery score in the morning. And the problem with the recovery score is that even if you feel okay, you're getting this recovery score that tells you that you're not quite recovered. So it creates this like hypervigilance scenario. And it's apparently, at least according to our 2025 data review, it's affecting people across the board. So I think there is a little bit of that with these wearables.
Yeah.
You know, it's a double-edged sword. It's useful to get patients thinking about self-management and the appropriate sort of layers of care that they need to be implementing for themselves. But then when it gives you this, you know, cautionary response about your recovery or whatever, your lack of steps, it can create a little bit of hypervigilance and catastrophization. So yeah, any thoughts on that?
Go ahead, Don.
I wasn't aware of that study when I saw it, but it stands to reason. I mean, that's, again, if you just understand human nature, when you know, people start getting all this granular information about themselves without, you know, especially without the ability to really understand the big picture with this, and of course they're going to start become hypervigilant. And get freaked out over minor things that they don't know if they're minor, because they don't know enough to know it's only minor, you know. So that's I'm not surprised that effect has happened.
The power of suggestion. Same thing with sleep trackers. You know, you wake up and you feel pretty good, like I slept pretty good, and then you look at your sleep score and say, "Oh my God, I guess I didn't sleep well."
Yeah. Yeah.
Now, David, is your device, is it a ring? Is it a bracelet? Oh, it's the...
This is the device. It's a screenless device that connects to your phone.
Okay. All right.
Yeah.
And what is it actually? Is it monitoring your pulse, your...
Oh, it measures a whole range of metrics. It's measuring obviously the basics, the sleep, your step count, your calorie burn.
Okay.
It measures a couple of other very interesting metrics that are becoming more significant in the domain of cardiovascular health, which is heart rate variability.
Okay.
So your ability of your autonomic nervous system to essentially balance loads.
Yeah.
Yeah, that's an interesting measure that I found actually ties closely with how I feel.
Do you know chiropractors had heart rate variability devices back? When did I start practice? In the early 80s.
No
In the
way.
early 80s, they had these things. They were measuring heart rate variability
Wow.
and using it. I mean, I think it was, I don't know that they were using it in the context that it was truly meant to be used or not. I'm not sure because I didn't know enough, but I absolutely recall that some chiropractors were measuring heart rate variability back then.
And back then, that would have been considered quackery and
Yeah, absolutely.
fringe science. But now it's becoming mainstream. There's a
Now
lot
you
of
can wear a
research.
device on your wrist that does it.
Yeah,
Yeah,
Yeah.
a little justification to our forefathers.
there we go.
A little redemption, I should say.
Yeah,
It also reflects a trend that we've seen in recent decades about we need to make sure that be completely transparent to all patients. They should know everything or be able to know everything.
Yeah.
And that sounds pretty good, but sometimes knowing stuff is detrimental to them. You know, what you don't know doesn't hurt you in a lot of cases.
ignorance is bliss.
Exactly. Let's be really judicious about this.
There has to be a balance there, right?
Yeah.
Not telling him anything is not a good idea, but telling him everything, I'm not sure.
So I just reviewed a study yesterday, and I didn't really get into the details too much, but it was a group that I am aware of that studied the use of tracking devices in patients with NEOA, and their goal was to increase their levels of physical activity, and they had a comparison group, which was just usual care. And they actually found, I was surprised because I thought I was going to see this positive, association. And they said there was really no difference in their outcomes. So I think there's a lot of effort to really, to use technology in ways to promote conservative care. And there's a tremendous amount of resources now in that. And I know that the CMS is really putting a push on this too, because they see it as potential, cost savers. The more independent people could be with their care, with tracking devices versus in office care. So anyway, I think they're still trying to figure it out.
It may be there are patients the key is, can you identify those patients who are most likely to be susceptible to the benefits of a wearable?
Exactly.
If you can do that, then I think then you hit a home run.
And what's the balance between, as Brian would say, touch and tech?
Right.
What's the right balance? So.
Yeah. What is the average cost on these devices? Like an Apple Watch is several $100, but.
And then there's Fitbits.
They range from like $60 all the way up to $300.
Okay.
Pretty much. Yep.
Yeah.
Okay. Because, from a cost standpoint, there may be, it may be easier to just give it to everybody if it's cheap enough and just, figure that a percentage aren't going to use it or work and be motivated by it. David, does your device give you any type of a gaming, where it gives you feedback to reward you if you do more steps? Or
there's a really interesting gamification feature built into it, which it's going to be interesting to see what happens. But let me actually, this might be fun to actually pull up on screen, since we're in a fun 2025 year in review. So
it was a fun year too.
Yeah, let me pull it up on my on screen. I've actually got the app on my computer. So, okay, so here it is. All right, so now here's my recovery score, which was apparently not that great last night, but my sleep score was good, and the two are different. That's going down a rabbit hole we don't need to go down. It took me long enough to figure out what the difference is. But here is probably one of the most interesting elements of gamification that I've ever seen on one of these apps. So this is what they call your health span. And they've actually got some really good science behind this. So the health span is what they consider your health span age versus your biological age. So just for context, I'm nearly 40. I'm 39 and I'm 40 in 3 months. So based on my lifestyle, it's got me 3.7 years younger than I am, which is quite cool. And so you can basically drill down to see how this is affected. So, which is interesting because there's good science behind all of this. So sleep consistency, hours of sleep, strain. So this is heart rate training. So the zones of training, and this we know from like cardiorespiratory research that zone 2 is excellent. So they sort of balance the number of hours expected in these zones. Then they incorporate strength training as well. And we know that that's good from the research in terms of lean muscle mass as you get older as an indicator of longevity. Number of steps, VO2 max, resting heart rate, etc. And then it gives you this trend. So, and then it kind of coalesces it all together and gives you this gamified end result, which is quite cool.
Yeah.
So this is one of the things that has made Whoop quite popular because it kind of appeals to those longevity lifestyle folks, you know.
So how quickly does that change, David? I mean,
it updates once a week. Okay. So it takes I think it takes 120 days before they give you your Whoop age. Okay. And then so it's got to collect 3 months worth of data. I think it's 90 days. It collects 90 days worth of your data, and then it gives you your Whoop age. So very interesting, and it kind of encourages you to keep a focus on some of these key areas like sleep consistency and your strength training and so forth. So
that's one thing. It does appear to have and people who need something pushing them a little bit. It certainly has benefits with regard to that. The hypervigilant tendencies of a lot of people, that's where it can be problematic.
Right.
But certainly in somebody who needs motivation, external motivation, it's a pretty nice thing for that purpose.
Yeah.
And I think if you're approaching it from like the long range strategy rather than a short range, so you're not taking your cues based on how you are today. It's how your whole week was, how your whole month was, and that's even the case that we see in MSK Care, isn't it? I mean, we encourage patients to not make a judgment call on how they're doing based on how they are today. It's how they've been this week versus last week.
Yes.
So same kind of principle.
Were there any suggestions, David, on how to counter the nocebo effect from these wearables since there isn't a provider involved? I mean, just take your chances, buy the device and hope for the best.
I think the feedback in the article was that there needs to be just careful de-escalation on the part of the provider with those patients. Education about the good trends and de-escalation, and just careful cautions about hypervigilance. Yeah.
I'm wondering if the research into the potential nocebo effect is probably brand new. So often with these kind of things, new technologies, it seems like everything's great about it. There's no reason to even bother thinking about, is there a downside? It's everything's great. Well, that's never the case in
Yeah.
anything that we do. There's not never is everything great. There are downsides, So they're just starting, it seems like, to investigate, is there a downside?
I think it's going to have to change a little bit, a tiny bit, how a history is done now, right? I mean, uh, before they started to understand some of the herb drug interactions, nobody asked, "Are you taking any herbs?" Then they learned, oh, herbs and drugs can interact, and you can potentiate the effect of a drug by being on a particular herb. So they started asking that. And nowadays it's not uncommon at all. As a part of a medical workup, they ask about vitamins or herbs that you're taking. I think they're going to have to start asking, "Are you wearing a wearable device?" Because of this potential for a nocebo effect.
Well, actually, one of the things that happened this year was Whoop got into a big fight with the FDA.
Oh.
So what they got into a fight about was so Whoop has this thing called a blood pressure insight. So I'll show you here on my thing again. So they have this blood pressure insight that it's an estimate of what your blood pressure is on any given day. So as opposed to being an actual blood pressure measure, which it can't give, it gives you an insight. They're specific about that word. And what you do is you calibrate the device. So you do a reading at a specific time. You do like 3 readings back to back, and it calibrates what Whoop gets in terms of all of its other measurements, and then it estimates where you're at. And then each day when you wake up, based on Whoop's data, it gives you this insight on where you are. So the FDA got into this massive fight with Whoop about, they were saying, no, you can't be saying this. This is not a blood pressure device, etc. And Whoop was like, no, we're not saying it's a blood pressure reading. It's a blood pressure insight. And so, yeah, this kind of data, if it can be scientifically validated, I think you'd find would be very helpful for cardiovascular consultation.
So it seems like it would be simple to do just a validation study. Just take the blood pressure and compare it to what the Whoop device is inciting about.
Yeah.
Yeah, it seems like a pretty easy study to do.
Yeah.
Yeah. Yeah, maybe they will. I know they do have some wearable devices, which I believe do give you your blood pressure. That actually is a blood pressure reading. Interesting. Yeah, David, thanks for bringing that up. That was really fascinating.
Yeah.
Next topic I'd like to throw into the mix here is the University of Pittsburgh. Their Doctor of Chiropractic program started in the fall of 2025 with their first class. Do either of you know how many students in that first group?
I don't remember the exact number, but it's in the range of like 30, 40, 50. It's not a big class, but
no, but that's better.
It's better. It's an advantage for those students also.
Okay. At least they mentioned in one article, 4 of the chiropractic colleges enrollment was up in 2025.
Oh,
yeah. So enrollment increased. So this is a wonderful thing. As far as I know, they are the first research heavy public university to include a Doctor of Chiropractic program. We have some other colleges, University of Bridgeport, but I don't think they're public. I think that's a private college. Duville College in Buffalo, New York, has a Doctor of Chiropractic program. And again, I think they're private. But neither of those two is a research intensive
Right.
institution,
Yeah.
with
Right.
a medical school, a dental school, and a nursing school, and a physical therapy school. And there were a couple interesting things I learned about the program. Their focus is early clinical exposure. So they're starting them on at least observational clinical work almost immediately. So their first year is observation of clinical work, but at least it's engaging them in a clinical realm. And secondly, their focus is on interprofessional collaboration. So to a certain extent, they're not just preparing these people to pass the boards, although they are doing that. They're preparing them to function in a interdisciplinary model of care, which I think is brilliant.
That's great.
They'll also have exposure to the research there, and all the other professions. So yeah, preparing them for an integrated model of care. They did mention one thing too, that entry requires a bachelor's degree. So one of their enrollment criteria is a bachelor's. I don't know how across the board that is for the other chiropractic colleges.
Yeah.
You know that.
I don't remember. I know it was I think national at one point implemented that requiring a bachelor. I don't know of any other school that ever did that as a formal requirement.
Okay.
Yeah.
I'm not sure.
Do you
And,
know if they have a research component? Do they have a research component in their in the program requirement for the students?
That's a good question.
Don't know, but it would be wonderful if they were
Yeah.
required to do some type of thesis,
Yeah.
Yeah.
Yeah. I don't think I haven't spoken to Mike in a while, but my conversations I had, I didn't think that was a planned thing, at least
Okay.
at the outset.
Okay.
But of course they had their hands full, just all the other things that you had to do, putting together a chiropractic program, and curriculum, and all that. So,
Yeah.
I had the opportunity to do a guest lecture. I taught one of their classes in their first year. I presented the PSP model and CRISP.
Oh,
and
beautiful.
and I didn't know what the response is going to be, because I thought, these are first semester students. They're probably thinking about all the things they have to, juggle, and are they going to be really interested in all the down the road stuff that I have to say? But they were very engaged. A lot of them asked really insightful questions, and it was really, really impressive.
Yeah, that's great.
Wonderful. Don, did you do it live or did you do it Zoom?
No, I did it by Zoom or Teams. I don't remember, but yeah, so
Okay.
it was from a distance.
Yeah.
But it was really interesting. They were bright and inquisitive and dedicated and really interested in what the long term, what they're going to do afterwards and all that kind of thing. Forward thinking like that.
Yeah. Oh, that's wonderful.
Yeah.
That's wonderful. It'll be really fascinating to see the interprofessional exposure that the chiropractic students get during the program. Meaning, do they get to, how much will they be able to interact with the physical therapy students, and how much will they be able to interact with medical students?
Yeah, I do know they're the two areas that they're really focusing on with that is the VA and FQHCs.
Okay.
So which is a great environment to have that experience with. Hopefully they'll expand it into other areas, but I think those are two fruitful areas to start.
Yeah. Oh, that's wonderful. Yeah, it's really exciting. I came across, and I'm not familiar with this at all. There's a university in Alabama, Troy University, that has applied to start a chiropractic program, and they are a public university too. I don't know how much research. I'll have to look up the college. But the Alabama Commission on Higher Education has approved them to start a Doctor of Chiropractic program.
Yeah.
So it's great to see these independent.
How many programs are there currently in the States?
16?
15. I was going to say somewhere between 12 and 15 as far as I know.
Yeah.
Yeah.
Interesting. Go ahead.
I was just going to say that it wouldn't be at all surprising if the standalone chiropractic school will be non-existent.
Yeah.
You know.
Yeah, I mean, there's a tremendous amount of growth in PT programs. There's hundreds of PT programs across the
Wow.
states.
Mm.
And there's some concerns about, expansion, but
Well, it's interesting. I was reading today. I forget where I saw it. Their data that I think chiropractors, the chiropractic workforce is projected to increase by 15% or something over the next few years. And I think what I read was that they're the only professional group that is expected to increase over the next few years, or at least maybe not the only one, but more than any other professional group. Their projected expansion is greater than other professional groups.
how does that compare to the workforce and the demand, I guess, on the workforce? Because that's the big issue is, right now is workforce shortages potentially among providers.
Well, and I wonder if that's what drives the projected increase, is because of the increased demand on primary care practitioners, for example. That may be what at least part of what drives that expectation, but who knows? And the one thing that the advantage, I was thinking about this before, I forget what topic we were talking about, but it relates to that as well, is that we as chiropractors tend to lament the advantages, that perceived advantages in our view, that physical therapists have, being already integrated and all these other things. But in the healthcare system at large, chiropractors are seen as physicians, and physical therapists are not.
Yeah.
And that's a big advantage that we have.
Yeah.
I would love to see that change amongst physical therapists. But,
don't get me going on that. And interestingly, with the education department right now, they're changing their guidelines for federal loans. They don't even include physical therapy as a professional educational degree. Chiropractors are. Chiropractic degrees are.
Yeah.
But not physical therapy.
Yeah.
And it's created this huge, revolt.
Didn't they leave off nurse practitioners too?
Yes.
Which just blew my mind. I mean, they can practice independently.
Yeah.
It
I know.
blew my mind. The level of ignorance on the part of whoever developed that rule and regulation. It's like, oh my God, how could you not? I mean, like I say, a nurse practitioner, PAs can't, but nurse practitioners can have a separate practice unto themselves.
Right.
I think under the direction of someone else, but they're on their own. Yeah, it's crazy. The world is a little nuts. I heard one, I think, potentially very exciting thing for the chiropractic profession on a national front, and that is there was at least discussion, and I don't know how far it got. I wasn't able to find more details, between the National Board of Chiropractic Examiners and the Federation of Chiropractic Licensing Boards of merging. To me, here's the significance of that. Right now, there are 50 scopes of practice for doctors of chiropractic in the United States.
Yeah.
There are 50 rules and regulations about continuing education for chiropractors in the United States.
Yeah.
It's having had to deal with that through our company. It's a nightmare and a madhouse versus the medical profession. Not that we should follow them on everything, but on this, they seem to do pretty good. They have organizations that are authorized to deliver Category 1 AMA PRA continuing medical education credits, right? Good in all 50 states.
Mm-hmm.
Good in all 50 states. Here, we can't even get a national, pace to cover most of there are a large group of states. I think at most they cover is 28 to 30 states.
Right.
So if the two would merge, I think it at least opens the door for a more uniform licensing and more uniform continuing education. How are you going to govern it all?
Yes.
Right now, there are 50 different scopes of practice.
And hopefully the identity will change. Like, because basically a chiropractor is a different thing depending on what state you're in.
Yeah.
In some ways, what is a chiropractor? Well, it depends on the state you're in.
Yeah. Very. Yeah. Oh, great. Let's see. What were the other things that I think really I can bring this point up, but there's really nothing to discuss. They've implemented HR 5 this was back in January of 2025. They submitted HR 539 bill, and that was the corresponding Senate bill was Senate 106, which was the Chiropractic Medicare Coverage Modernization Act of 2025.
Yeah, right.
So that was 12 months ago.
Yeah.
It's still in committee.
Yeah. Okay.
Never moved out of committee.
Okay, that was the very thing I was going to bring up to see if anybody, because I've been following it a little bit, but not recently, where things are at. So it's still in committee.
It's still in committee as of December 2025.
And bills can stay in committee for a very long time.
Yeah.
I mean, that is, I was going to say likely, I think undoubtedly the most important piece of legislation in our careers.
Yeah.
I mean, that's so huge. I don't think it can be stated strongly enough how important that is to our profession.
Yeah. Because as Medicare goes, so do Blue Cross Blue Shield plans.
Yeah. Yes.
So it would be an enormous impact, but I was so disappointed when I heard it's not made it out of committee yet.
Oh, God. Well, one thing seems to be happening over the course of this year is that we've had increasing numbers of what's the term that you use when a congressperson comes on board with it. Whatever the sponsors. Yeah. So sponsors have steadily increased, I think, over the throughout 2025. So that is good as far as it's the likelihood of passing. When is a different story.
The key position is the committee chair. They get to decide what comes up for a vote. So
and to think that Congress could possibly think that something is more important than this. I mean,
how could they? How could they possibly? What is it? You don't want to know how sausage is made, and you don't want to know how bills are passed.
John, maybe for the last couple of minutes, we could discuss the Ozempic situation.
Yeah, David, I think you probably have.
Yeah, I'll preamble this.
Perspective on that.
Yeah. So this is actually from this came up in an endocrine publication. The study title is Skeletal Muscle Mass Loss and GLP-1 Receptor Agonists Are Older Patients at Risk? And the finding, basically just the summary of this for the sake of this meeting, is that GLP-1s, so specifically Wegovy, Zepbound, Ozempic, are miracle drugs for weight loss. This major review found that 15 to 40% of the weight loss is lean muscle mass, which is accelerating sarcopenic obesity in older adults. Patients who look thinner but have the skeletal stability of a frail geriatric. So actually, there's a few things to say about this, but there's actually one helpful takeaway, and that is from a marketing point of view for MSK practices, and that is a clinical and marketing takeaway, which is add resistance training programs to what you recommend and do. If you have a mini gym in your clinic, use that and promote it, because it's not just self-promotion. This is going to be genuinely useful and helpful for people that may have undergone some of this lean muscle mass loss, which may have come by necessity from being on one of these GLP agonists. So yeah, that's an interesting little takeaway and a practical point for MSK clinics.
This has been a huge topic in the physical therapy world for over a year now. A lot of papers published on it. Going back to the changing in taking a history is you should know if your patients are on these drugs. But yeah, prescription of resistive training is very important. It's critical because you're right, and the loss of lean muscle mass is also contributes to the phenomenon where you go off these drugs and now all of a sudden, you're very likely to put on the weight. So it's a very unhealthy, cycle for patients.
Yeah.
But there's all kinds of implications, and one would be balance. Balance, and so these people are going to be more susceptible to falls and injury. So yeah, it's a huge issue, and it's a good thing to be aware of. The OA Action Alliance actually just had and I think Brian Justice was on that last week, where they ran a clinical trial looking at putting a program together for people on weight that have OA, and just again monitoring them for their ability to actually maintain their weight or potentially lose weight while continuing on an exercise program. So the feasibility, they're just looking at the feasibility right now, because we still struggle with getting people to follow through, on the recommendations for exercise. So,
yeah. Well, yeah. Whenever anything like that becomes all the rage, that's when I get nervous.
Yeah.
All the rage when it comes to a medication or something never turns out well.
No. I mean, it is that magic bullet people were looking for, right? Can I take a pill, get an injection that's going to, give me what I want, which is weight loss? Well, yeah, but here's the price you pay.
Yeah. Like Thomas Sowell says, there are no solutions. There are only trade-offs.
Yeah.
Yeah. And it's, people struggle with this, and medical practitioners struggle with this because, again, there's, it is a trade-off, right? And it's almost as though the pendulum has swung so far that I've actually heard people that I respect say, well, your weight, I don't really talk to patients about their weight because it's not within their control. And when I hear something like that, I think, whoa, the pendulum has to be in the middle here. The weight loss is important because it is, depending on who you listen to, it's a disease in and of itself. It drives, it's such a risk factor for every other disease. And so controlling it is important, but how you control it is important.
Yeah. 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 Wonderful. Well, we're right at the top of the hour. So thank you all. It was a wonderful exercise, David. Thank you so much for suggesting it.
Yeah, it was great.
It's a great way to wrap up 2025. And I think what we probably need to do on our first of 2026 is focus on where can we go in 2026 for our first office hours.
Yes. Yeah, good idea. Yeah.
Yeah, we do have a webinar in the beginning of January. That first, I don't know if it's the first or second Wednesday. I'll have to look. I think it's the first Wednesday of January. But then the third Wednesday in January, we'll have another office hours, and I think we can follow this lead and talk about where we can go in 2026.
Yeah, good.
Yeah. So happy holidays to each of you.
Yes.
And, a very happy and blessed new year.
Yes, you too. Thank you. Okay.
Bye-bye.
Okay, all. Bye.